Good morning, everyone. I'm Dr. Pooja from MRRCH Hospital. Today's topic is physiology and development of oromotor function. Coming to the embryology, as we all know, that primitive gut form pharynx, esophagus, stomach, as well as the airways, lungs, and diaphragm. All these organs share a similar sensory motor control system. Coming to the cellular components, which are used for coordination for neuromuscular activity of sucking, swallowing, which appears earlier as maturation occurs, and there is integration occur in between the mid and late gestation. Now we'll see the difference between the infant and adult anatomy. As you can see, the figure 1 is of infant and B is of an adult. Now in infants, the oral cavity is small compared to the adult and the palate is flatter. You can see the tongue is quite large and the epiglottis is touching the soft palate. Whereas in figure B, the larynx is on the lower side compared to an infant. Now this is the most important slide of my presentation, that is oromotor development. As you can see, the red arrow is suggesting of the postmenstrual age in weeks. As we all know that swallow reflux comes first, that at 11 weeks, so baby tends to swallow the amniotic fluid without any coordination with suck and breathing. At 18 to 20 weeks, there is slightly suck activity is seen. Whereas in 26 to 29 weeks, there is slightly coordination, that is 1:1 suck and swallow, but it is not coordinated with the breathing. Gradually, as the age increases, the increase in frequency and amplitude can be seen, and later there is consistent rhythmic patterns and suck bursts are noticed. At 30 to 32 weeks, there is coordination between the suck and swallow, but not coordinated with the breathing. At 34 to 36 weeks, there is all three coordinated, that is suck, swallow, and breathing. Coming to the developmental maturation of the oral feeding, we can see that there are three stages, in which first is voluntary and the second two are involuntary. Now in figure A, you can see there is a food bolus which is pushed to the back of the oral cavity, whereas the tongue get against the palate. The nasopharynx is sealed off gradually and the larynx is elevated, which enlarges the pharynx to receive food. The pharynx sphincter contracts sequentially and squeezing the food into the esophagus. Then the epiglottis closes in the trachea. The bolus of the food moves downward gradually, the esophagus by the peristaltic contraction. Now in early infancy, this process of suck, swallow, and breathing is regulated by brain central pattern generators, and they are capable of rapid rhythmic motor patterns with cortical sensory inputs. Whereas these are used for sucking, swallowing, breathing, which develop in the parallel way in early gestation, and they learn to interact and coordinate with each other in advanced gestation. Now, as you know that baby is always with the mother, and there is tactile sensations, taste and temperature, vision. In this critical period, they get very coordinated from the critical input. Now there are three phases. The first one is oral, then second is pharyngeal, and third is esophageal phase. In oral phase, it is implicated in the formation of the bolus by sucking, whereas this pharyngeal phase is implicated in the safe and efficient transport of the bolus into the esophagus by eliciting the pharyngeal swallow reflex in coordination with upper esophageal sphincter opening while ensuring the airway protection. Whereas esophageal phase is implicated in transport of the bolus towards the stomach by sequential peristaltic activity. Coming to the development of the sucking, the oral phase of swallowing in early infancy is primarily brainstem mediated reflex, that is sucking reflex, with the goal of compressing the nipple and expression it contains. Now it is divided into two types, non-nutritive and nutritive sucking. As you can see in the figure, this is non-nutritive sucking, which is usually followed in preterm, where there is no introduction of the any fluid. Now it can be done by either pacifier, finger, or just empty breast where there is no milk transfer. There is an oromotor rhythmic movement that appear between 28 to 23 weeks of postmenstrual age in preterm. As you can see that this figure A, that is the early gestation where there is poor suck and expression, and there are not much of suck breast burst are seen. Whereas the figure B, where the baby is almost on the 8 oral feedings per day and how good the contractions and the suck and expression is noticed. Now, how we can say that it is quite mature? So we can see there is a lot of suction and expression is going on with 6 to 12 cycles followed with a pause which accommodate the respiration. So all three coordinations are noticed in this. Now, in non-nutritive sucking, it involves milk transfer, ingestion of milk 1 cycle per second. It has lower pace and allows coordination. Now, there are 5 stages in which the first you can see there is no suction and there arrhythmic expression, which gradually increases, and the increase in amplitude and frequency is noticed when it comes to the later infancy. So you can see the last figure 5 that the amplitude is quite high, it is rhythmic and well defined, and even the suction pattern which are similar to the full terms. Coming to the development of the pharyngeal swallowing, there are subpharyngeal coordination and pharyngeal and upper esophageal coordination. In pharyngeal coordination, the soft palate get elevated to close off the nasopharynx and preventing the bolus regurgitation into the nasopharynx. The vocal folds close to seal the glottis. The larynx moves upward and forward by suprahyoid muscle, that is hyolaryngeal elevation. The epiglottic tilts backward. The hyolaryngeal elevation results in active opening of the upper esophageal sphincter. Pharyngeal constrictor muscles contract sequentially from the top to bottom, squeezing the bolus downwards via, then open it in upper esophageal sphincter, and then it goes into the esophagus. Now, development of respiratory coordination. In adult pattern of swallow, which appears in late infancy, there is always exhale, swallow, and exhale, which helps in airway clearance. Whereas in preterm, in all phases, there is respiration. So most commonly at 32 to 36 weeks, they follow deglutition apnea, where with pharyngeal swallow. So there is deglutition apnea, swallow, and then deglutition apnea. So usually we see there sometimes there is bradycardia and desaturation while feeding. So this is because of that. Eventually, there is inhale, swallow, and exhale pattern, which is in healthy term babies. Exhale, swallow, exhale, then evolves by 6 to 9 months of age, which is an adult pattern. Coming to the esophageal motility, there is peristaltic waves which carries bolus down into the stomach from upper esophageal sphincter to lower esophageal sphincter. Esophageal motility consists of peristaltic waveform and non-peristaltic waveform. Peristaltic is in antegrade and retrograde, whereas non-peristaltic waveforms synchronize and incomplete wave patterns are seen. In esophageal peristaltic, there is esophageal deglutition reflex, where peristaltic response is triggered by the pharyngeal swallow and accommodated by respiratory pause. Whereas in secondary peristaltic, there is small independent peristalsis triggered by the esophageal provocation. Coming to the retrograde peristaltic and non-peristaltic esophageal motility, which is in preterms, which cause gastroesophageal reflux. Now, there are some clinical tools to evaluate this oral feeding, like upper GI fluoroscopy study, video fluoroscopy swallow study, fiber optic endoscopy evaluation of swallowing, multi-channel intraluminal impedance pH monitoring, and pharyngoesophageal manometry or high-resolution impedance manometry. Now, there are some infants which are risk with feeding difficulties, which is mostly seen in chronic lung disease of prematurity, gastroesophageal reflux disease, and hypoxic ischemic encephalomyelitis. Now, coming to the infant at risk of feeding difficulty in chronic lung disease, due to prolonged respiratory support, they are deprived of sensory and oromotor expression. In now, multifocal etiology is seen in this. There is lower suck pressure, lower suck frequency, shorter sucking burst duration, and lower frequency of swallows. Now, suck, swallow, breathe coordination is delayed in these babies. There is deglutition apnea, which is not tolerated. So, feed-related cardiorespiratory compromise is usually seen. Now, orosensory aversion secondary to tubes, cannula, and tapes on the face is noticed. Now, in GERD, there is often implicated causing apparent life-threatening events and brief resolution unexplained events. These are common in immediate postprandial period. So most likely non-acid GR, whereas acid GR, where acid suppressant medication is likely to act. These are later during the feeding. The best objective test in this will be 24-hour esophageal pH impedance study. In hypoxic ischemic encephalopathy, there is increased skeletal muscle tonicity at upper esophageal sphincter and proximal esophagus, whereas deglutition at lower esophageal sphincter. There is pooling of secretions you can see in the baby, and inadequate airway protection and gastroesophageal reflux.